Good evening, everybody. Welcome. I'm really happy to welcome you all here for the final evening of our symposium. I'm Amy Lesson. I'm a faculty member at the Dillard University Minority Health and Health Disparities Research Center. And tonight is the last night of 4 consecutive nights of symposia that have been really wonderful. We've had a really great diversity of speakers and perspectives. Last night we had Dillard students, and we've heard from a really interesting group of experts, and we have a really wonderful evening of discussion for you tonight. So I just want to first acknowledge Tiffany Kirkwood, who is my colleague at the Minority Health and Health Disparities Research Center at Dillard, which we affectionately call the MHHDRC. Let me just say a couple of things about the MHHDRC before I introduce our speakers. The Minority Health and Health Disparities Research Center at Dillard in New Orleans is funded by a grant from the National Institutes of Health branch, the National Institute of Minority Health Disparities, and it's an endowed center, and it's dedicated to improving the health of underserved populations in New Orleans, surrounding regions. And the Dillard University Minority Health and Health Disparities Research Center, we research health and healthcare inequalities among races and people. And in addition to conducting research, we inform the public and hold events like this to address health disparities in communities. And we've been around since 2012, and we have undergraduates that work with us, with our colleague Tracy Thomas, as pre-health scholars. And one of the things we do is events like this. So one of the things that I wanted to make sure we included in the symposium this week was the perspective from clinicians, physicians, and other people in the healthcare industry and healthcare field who've been working on the front lines with people during this time of the pandemic for COVID-19, and also to talk about medical school education and issues of disparity in that context as well. And so with that in mind, I invited my colleague, Kristie Anderson, and she invited 2 of her colleagues, Dr. Nick Sells and Marilyn Marshall, Dr. Marilyn Marshall. And let me just read a little bit about each of them before we get started. So Dr. Anderson works for the LSU Health Sciences Center as the Director of Medical Education, where she and her team work on in the public hospital, the Austrian University Hospital and Clinic. She works with the Associate Dean for Lafayette Affairs. So she works at the LSU Health Sciences Center in Lafayette, Louisiana. And she works with the Associate Dean for Lafayette Affairs, clinical teaching faculty, fellows, residents, and medical students, creating and developing assessment tools, remediation measures, and maintaining accreditation standards and policies for the sponsoring hospitals and residency programs. She also serves as the student ombudsman and the diversity liaison for the Lafayette campus, where she works to create safe spaces for all medical learners as they work through any personal and professional challenges. She also works with the LSU School of Medicine Office of Diversity to provide discussions and events to highlight world events, conversations on race, and how the intersection of race and medicine are postured within our healthcare system and communities. And she received her Bachelor of Science and Master of Science degrees from LSU in Baton Rouge. And she completed her doctorate in systemic studies from University of Louisiana Monroe, where she examined the role that race and ethnicity play in the experiences of medical school admissions committee members and their ability to influence selection. And Dr. Anderson and I met as members of the Louisiana Governor's Task Force on Health Equity in COVID-19. And I'm really pleased to have her here tonight. Dr. Nicholas Sells received his Bachelor of Science from the Tennessee Technological University in Cookeville, Tennessee. He went on to receive his medical degree from Medical University of the Americas in the West Indies. He completed his residency in internal medicine in Houma, Louisiana, and his fellowship in infectious diseases at the University of Mississippi Medical Center in Jackson, Mississippi. He's been with the University Hospital and Clinics in Lafayette, is that correct? Since 2016, and serves as the section chief and associate professor of the Department of Internal Medicine, as well as the director of infectious diseases, HIV, and the viral hepatitis clinics in Acadiana. As the chief of medicine, he oversees and supervises the medicine faculty, which provides hands-on instruction to the medical students within the department, as well as the internal medicine students there. He's also the course director of infectious diseases and developed a curriculum and rotational experiences in HIV, viral hepatitis, LGBTQ medicine, and general infectious diseases for internal medicine residents, as well as 3rd and 4th year medical students. And we're very happy to have you here, Dr. Sells. And Dr. Marilyn Marshall is from Tulare, Louisiana. She obtained a Bachelor of Science degree from Alcorn State University. She has very close ties to Alcorn. She also completed studies at Harvard while in college, and then attended medical school at the University of Michigan. She did her residency at the UAMS South Arkansas Family Medicine Residency Program. She later returned to become the first female and first African-American residency director in a family residence program in Arkansas. And she stayed there at UAMS South Arkansas as an assistant professor and the program director for 6 years. And she currently serves as program director for the LSU Family Medicine Residency Program in Lafayette, Louisiana. And there she provides academic and clinical oversight to 25 residents per year, simultaneously working to create innovative and rigorous curricula to strengthen the physician base in the Acadiana region of Louisiana. And she continues to provide care to patients 1 day a week at the Abbeville Community Health Center in Abbeville, Louisiana. Her clinical interests are in obesity and women's health. And I know that my students in the audience will be excited to hear that Dr. Marshall is an AKA, and she's very active with AKA. So without further ado, I introduce Dr. Anderson, Dr. Sells, and Dr. Marshall, and they're going to have a conversation, and then we'll have some Q&A.
Thank you, Dr. Lesson. We are, if I can speak on behalf of Dr. Sells and Dr. Marshall, we're so excited to be here. And, you know, we've kind of chatted about what it is that we're going to talk about and who's going to talk and who goes first and everything. And then we look at the time and it's like 5:13 and we're all just like run down from the day because we're in the middle of interview season. And so we have been interviewing applicants for residency positions. And of course, you know, my colleagues here are working in the clinics as well, seeing patients and navigating all the ins and outs. So it has been quite a day. So I hope that you'll be okay with maybe, you know, me kind of stammering or stuttering a bit because, you know, I'm trying to gather myself and collect myself about what to say because there's so much to say. So I guess what I can start off with is to speak about medical education and where we are and what COVID has kind of unveiled for us and what we have been discussing in terms of disparities for quite some time, not just since the curtain was pulled back over the last 6 to 9 months, but basically what we have been doing here at University Hospital and Clinics. A lot of people don't know that LSU Health Sciences Center has like a satellite campus here in Lafayette. And it has been the site for medical education for decades. And this hospital has provided not only a training ground for medical students and for residents and fellows, but it has also given the community a safety net. And when we talk about that safety net, of course, we understand in healthcare that safety net is just kind of a place where all individuals can walk in, receive care, no matter if they present with a wallet, a card, or nothing at all. It is the place that has been the kind of catch-all for anyone, everyone that needs healthcare. We have become the net, the bowl that provides our community with the best care possible. And in that are a host of physicians, of medical fellows, residents, and students. And so you have this tier of clinicians that you would never or not normally see in a private hospital or a non-academic teaching center. And so that tier, in my opinion, is such a unique and beautiful way to practice medicine, because all of those levels have a different perspective. And that perspective brings about just organically a way of inclusion. Now, what that looks like for individuals, of course, varies based on background, based on worldview, based on their own personal experiences. But I would venture to say that here in our safety net hospital, our training goes beyond just the clinical skills, because what it is that we start, or we challenge everyone to think about, is opening our minds, opening our hearts, opening our understanding to what it is that our patients walk in and need. And sometimes it's more than just a pill or a diagnosis. Sometimes it's just the space of time. And, I think that COVID, I think that the conversation about systemic inequities, systemic racism, all those things that we've been hearing have really given us the space and time to dissect who it is that we are as a people, who it is that we are as humanity, and how do we connect or disconnect from others. UHC, I always say, UHC is such a place that allows me to kind of humble myself and see the face of humanity day in and day out. It allows me to share, I think, just kind of my own wants, needs, hopes for the future, hopes for myself, hopes for our future physicians that we're training, and challenge them to not just think about themselves in attaining clinical skills and procedural skills, but in challenging them to understand how do they deliver a system of equity to all. And what does that look like? You'll hear in a bit from Drs. Sells and Dr. Marshall what the delivery system in their specific areas looks like. But I think at the end of the day, when I think about all of our academic faculty, all of our physician faculty that are teaching our medical students, from surgery to GI to peds to family medicine or internal medicine, we're all trying to provide equitable, equal healthcare and opportunities to both learners and to our patients. And I feel like when a delivery system understands that for its community, there is an opportunity to build trust. And we've seen over the years that there has been a system of distrust and mistrust from our African-American community, primarily based on a historical span that we could spend a whole nother Zoom conversation on just in that. But I think with COVID, we've begun to see some of the structural challenges and things that have been systematically done that I think are allowing us to be able to have conversations that we normally would not have had with our learners, that also kind of opens their minds and opens their hearts into what is it that is unique unto a physician, that is an extender and a piece and a part of this delivery system, and how can I make a difference? What is it within a medical school or a medical student? What does that training ground look like for a medical student who then comes into a residency program, who then either goes into a fellowship program or a practicing physician that's going to continue with them and follow them through in order to provide this equitable healthcare? Because I know there's so many individuals out there that can be on whatever side that says well, healthcare, is it a right? Should everybody have? There's all kinds of conversations, but at the end of the day, when we can't give a person their dignity, when we can't give a person their quality of life, how in the world do we build and lift our community? And to me, I think that we have such a community here within the hospital with our physician faculty, within our learners, within our residents and our ancillary staff that are here helping to train our future physicians. But we think about this safety net, and we think about this hospital and what it does, and I feel like we're just like, we hold hands and we're just wanting the best for our community. And without their hands holding us, without their connection, we won't be as successful and won't be as fulfilled as healthcare providers that we should. And so I look to this kind of bidirectional relationship that we have to have with us in the healthcare system and our community leaning on us. And then what does that relationship look like? And how do we build that relationship with them? And we do that by having conversations about race and inequity and disparity. And my colleagues here are very strategic and are very thoughtful and deliberate about how they translate that into the exam room, what that looks like in a residency program, because it's not just something to walk in and say, I'm in a residency program, I'm here as a medical student, I'm here as a resident, training, and I've got to get my 3 years in, and then I'm going out in the community, I'm gonna make lots of money and drive nice cars. We teach them that no, we have a responsibility to our service. Our service calls us to serve. Our responsibility calls us to do great things. And that is, building a relationship. That is giving individuals their dignity, giving individuals, the respect that they need, treating everyone as if they matter, and once we build that connection, and once we build and establish that trust, you then see greater health outcomes. And the data says it. I mean, clearly when physicians create that connection and build that relationship, there are better health outcomes, which again only strengthens our community. I always think about, do we have enough of us? Are there enough of us out there, that kind of feel the same way or believe the same premise? I am very fortunate to work among those that choose to be in an academic center where they could be anywhere, but they choose to be here taking care of the community, which, for me is such a gift and such a blessing. But what we do is we have to go into our schools. We have to go into, and we have to start early. We have to start in our elementary schools with STEM. We have to start thinking about cultivating a desire and a want for healthcare in our underrepresented communities. We have to start thinking about how can we strengthen the want to be in medicine from 8 and 9-year-olds, and what does that look like? Because I'll be honest, in college, while there are some that may decide, hey, I can go into medicine, I think I'd like to do that, we want to start way earlier than that, because to me that starts just that engine going and that momentum, and where one starts thinking, they start planting the seeds for everybody else. And I just feel like it becomes this moving train. So there's a lot that we can do. There's a lot that we can do with our current physicians now to educate them on implicit bias, on structural inequities, on political determinants, on things like that. And I think collectively we have a long way to go. There is hope, and there are deliberate intentions. And I feel like together we can move that needle and we can start to make some changes. I don't know how much time I have, but I'm gonna pass it off to Dr. Sells, and then maybe we can circle back later after with some questions.
So hearing you talk, Dr. Anderson, I just have a couple A couple of things. So I know I'm supposed to talk about the interface with disparities and COVID-19, and I'll get there. But hearing you talk, I just have a couple of things. As Dr. Lesson and Dr. Anderson mentioned, I'm an infectious diseases physician, which means essentially I am an infection. My specialty is infections of different kinds. Right now, unfortunately, I have become the COVID guru, and that's where I spend my time directing policy, keeping employees safe, our learners, or our medical students, our residents, our physicians safe as we see patients, as we care for people, working with our community stakeholders and keeping our community safe. Leading by example, wearing my mask, those types of things, as simple as that. But also understanding the testing capabilities and advocating for more and better on a daily basis. That's sort of what my life has become lately, communicating, re-educating over and over about COVID-19 and what it would mean and what would the vaccine mean. And we talked, Dr. Anderson talked about historical mistrust in the healthcare community. And I'm seeing that and hearing that on a daily basis. And that's something that sort of, as it relates to when I think about COVID-19 and what that sort of the uncovering, I can't underscore that enough, and what that has meant and means to the patients that I serve on a daily basis. What I also do pre-COVID life, I spend my life as an immunocompromised infectious diseases doctor who has a special interest in HIV and hepatitis C co-infection specifically. I also have a large practice of HIV prevention, and I spend about a third of my time pre-COVID, or a fourth of my time perhaps, doing transgender care. And that's sort of what I loved to do pre-COVID. Now, COVID, while it has changed everyone's life, it has certainly changed my professional life fairly significantly. And when we talk about a story, something Dr. Anderson said made me think a little bit about the patients that we serve on a daily basis and what we do in academics. And I like to kind of share part of what I also do is I'm the chair of the Department of Medicine, and part of my job here is to recruit other doctors. And I hired an endocrinologist, and when I was thinking about where to place his clinic, I put his clinic with mine because part of the management of his patients, while they don't have infections or while they don't have HIV, part of the way we go about tackling some of the disease processes of patients, say with diabetes, are very similar to the way we go about tackling a disease process such as HIV disease. And what I mean by that is there's a disease management nurse, a case manager who touches that patient via telephone or in person 2 or 3 times between visits to check on that patient, to manage that patient, to be sure that patient has appropriate food or supplies or access to medicines, those kinds of things. And so I thought, well, it makes perfect sense. We manage patients in a very similar way, even though they're separate patients. I think it's really prudent that because we do that similarly, to put us in the same space. Then the other thing is the endocrinologist and I both had very sort of busy private practices before we moved to academics. And one of my goals was to be sure that all patients, irrespective of payer source, were treated in the same way that I would want to be treated, or that our parents would want to be treated, or that any patient in private practice would expect to be treated. And my clinic staff did a great job of doing that for my patients, and they would do a great job taking care of his. The only pushback that I heard was, ooh, I don't know that his patients will care to wait in the lobby with your patients, Dr. Sales. And I thought to myself, my patients, what is that? It's a loaded question. Do you mean because they're Latinx or they're African American, or because that what are you they're transgender because they're part of the LGBTQ community? What are my patients? They're HIV positive. What are you saying? A, and then, or B, is it because they're infectious in your mind? What are my patients? I thought. And so I mulled over that for a little while. And then I had a conversation with him and I said, "You think this is going to be a problem?" And he's a little more OCD than most people in life. And he said, I don't really know, Nick. Do you want me to really think about it? And I was like, no. Let's just not overthink it. Just let me mull it around in my head. And so I wasted about 10 more minutes thinking about it. And then I thought to myself, well, if there's anything I've learned in medicine, or if there's anything I've learned in life, it's this, is that people teach you everything. And this is an opportunity for his people to learn from my people. And that's exactly what they did. There were 0 complaints. And when I say 0, I literally mean 0. All of the worry came from people who worked in our clinic who weren't the right people to be working in my clinic, that clearly identified themselves as people who shouldn't be working and with people at all. They should go work in a cubicle somewhere that they don't have to work with people. But it was all because they were uncomfortable with who they were or whatever their issues were. But there were 0 issues with patients. And that's absolutely true. My patients had the ability to teach his patients, and his patients had the ability to teach my patients. And all of our patients had the ability to teach our clinic staff because we eventually got new staff. And I think that is the true definition of what academics is. I had a new prep patient today, and I had a new learner in clinic. And because of COVID, this patient who's transgender female and brand new to the Lafayette community and brand new to my clinic, but I've been terrified to come see me because of COVID, and was seeing me and a learner and all of us. It's all new today, and she was mortified of the whole experience because the first appointment's rather shocking. You're meeting all these new people, and we're talking about something relatively sensitive, and then after about 10 minutes with me, she had kind of, okay, I feel better now, and now we're able to actually talk about what we need to talk about. And all her fears had kind of been allayed. And I looked at my resident who was working with me, and I saw his fears had finally been allayed too. And I thought, what's interesting is that COVID-19 had prevented her from being able to see me, right? But COVID-19 had also prevented him from being able to learn what he needed to learn by seeing her too. And it's interesting when I think about just that little educational experience that happened without me saying a word. He literally had never seen a transgender prep visit before, and he was just watching me do it. I said nothing to him, and he was literally just watching me have this interaction with this patient today. And afterwards, when I was kind of observing what was happening and kind of doing a debriefment with him after, I thought to myself, I don't think I realized even what COVID has done to the lack of education to the patients or to the residents that I teach on a daily basis, because I think that they're learning and they're learning and they're learning. But evidence today that's sort of proof that they're not getting the education or the robust education that they had been getting before. Now they're seeing all kinds of COVID-19 patients, but they're certainly not seeing the depth and breadth of patients that they had seen before, secondary to a pandemic. It's really interesting in that regard. It's also interesting when I think about the vulnerable population that I serve. So I believe that when you do what I do, I love to teach, and I love to design a curriculum that challenges people to reach for a bar. Whether or not they attain that bar and they can do a chin up, not important to me. What's important to me is that we've all reached, and that tomorrow, that they know that my commitment to them is that, and my commitment to their education is that I'm going to ask them to reach. And so over time, every day, everyone's arms are up, everyone's reaching. And my goals are that together we develop a learning plan that's individualized enough that I'm committed to your success. And that's what we want as a teacher. And how do we decide who's great at teaching and who's not? And I think mastery of the content is one. And I think two is commitment to the learner. And I think that we develop that here and doing what we're doing. But I think at the same time, what's interesting is learning, at least when you do what I do, as I'm seeing, my residents see me every day, but the vulnerable patients that I serve, and I believe that we're called to see who we see, but sometimes people heal people, and I believe that. And as you all know from a Zoom conference, it's difficult to get what you need from people via Zoom. And my patients specifically, sometimes they just need me. And I think it's difficult for them to get the healing from me that they need from me, like this. And, for example, there was a time when we were just seeing patients like this over a Zoom-like application. And I tried to do this for about 2 weeks. And I have a relatively robust clinical practice. And I don't classify patients as private patients or non-private patients. They're all my patients, and I love them. I couldn't tell you who's got what insurance. They're all my people, and I love them all. But the real truth is that I would have these kind of visits with them, and then they would say, "Okay, Dr. Jill, so when am I coming to see you?" And I'd be like, "Well, we just did it. Like that we just did. This was that." And they'd be like, no. So thanks for checking on me, but I'm gonna need and so I realized after a couple of weeks, like this isn't gonna work for my people. They want the real deal. And I think that that's true. I think that when we talk about a vulnerable set of people or a vulnerable population, and we can define a vulnerable populace a couple of different ways, and we can define a disparate population a couple of different ways. But when we talk about a vulnerable population and people, my group of people are minorities with HIV, or cirrhotic hepatitis C patients who have been out of treatment or neglected or denied for treatment because of histories of substance abuse, which is wildly inappropriate in 2020. But that being said, all of these things, when I think about it, I mean, kind of crazy, but denied access for so long. And then the pandemic happened and they're denied access again. And so some of them have no idea that they don't need me to get a refill of their medicine. They just need to go to CVS and say, "Hey, can I get more of my Biktarvy or Atripla or whatever it is?" They're that used to calling my nurse or walking up to my office and saying, "Hey, I need a refill of the medicine." And my nurse just saying, "Yes, sir. We're just go to the pharmacy, I send it," right? Because they do that every month. It's part of their social routine. It's part of their commitment to controlling their illness, right? And it's part of the social interaction that they need to feel good about who they are today and caring for themselves. But COVID changed all of that. And I've seen significant changes in people's health status baseline because that social interaction has gone away. And when I think about sort of social distancing, I think social distancing is great in the right scenario. In the middle of a pandemic, it's fantastic. But when we're talking about people who feel alone and isolated already because they might feel like they're not, they might feel like second-class citizens, or they might feel as though they're not as good as someone else because they have HIV disease or viral hepatitis, and they feel as though they're isolated. Then to remove them from society and recommend social distancing and masking, and to make people feel as they're not safe around others, just sort of cripples them even further. I mean, we've doubled our case management staff and converted one of our nursing positions to case management, so that I've got people calling my patients to, you're good, you've been to the grocery store, do we need food, you've got somewhere, all of these things. And I think those are things that we weren't thinking about before. Because and the other thing that I think is important is I know today who I haven't seen in a while. I can tell you there's 5 people who I haven't seen in 3 months. I can see their faces and I know their names. But with the COVID pandemic, we weren't allowed to have live visits for 3 months. That's changed everything. Before, I could tell you, you need to find so-and-so, 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 and so-and-so. And so I think access to care, access to me, access to my nurse, all of those things have created large gaps that we've needed to fill. And I think it's created bigger and bigger issues that we've uncovered that we won't have to uncover again, because they're clearly delineated now. But I think those are some of my larger. And then how do I keep everyone safe? I mean, I had a baby right in the middle of COVID-19, which was terrifying. And how do I protect an entire set of learners, employees, my colleagues, all my employees, my patients, I mean, 600 hospital employees, and my wife, and she can't be with her family, and my mother-in-law can't come, like all of the things. It's a lot, and all of us feel it. Even those of us who are, virus specialists. So I don't know. That's my thoughts. Dr. Marshall?
All right. Thank you. Thank you, Dr. Sells. I think I was supposed to talk about what it means to be, what it's like for me as an African American physician, treating patients and teaching residents, and also what it's like for my family life. But listening to Dr. Anderson and Dr. Sells, so many things have now popped up to talk about. You know, Dr. Sells, you mentioned, the scenario where it was like, my patients may not be with your patients. And, you almost reflect on Maya Angelou saying, when people tell you who or show you who they are, believe them. But I don't think that one necessarily applies. I think there was a lesson learned in that. And I'm glad to hear that. I work at a federally qualified community health center. That's in Abbeville, Louisiana. And no matter how much I tried to escape FQHCs or academia, I was drawn back into it. Or maybe I was led back into it. I'll put it like that, because I certainly think that everything that I have done has been God-led. The FQHC, I happened to be a part of that after getting a community health service scholarship to pay for medical school. And so one of the things that I had to do as a FQHC scholar was to serve in an underserved area. And I chose New Iberia, Louisiana. Always wanted to give back, always wanted to be part of that, given to people who need me. And when I got to the FQHC, we found out the types of patients that you see. I mean, these are your patients who have nowhere else to go. Federally qualified community health centers see a myriad of patients. Most of these patients are uninsured, underinsured, or Medicaid, where no one else is accepting in the community, and a large portion are Medicare now. And then you have the population that's on the sliding fee-for-service basis, where they pay a minimal amount, $15, $25 to see the doctor. And then they still have to try to get their medications all on that same $25 and get their labs done and say, well, doc, I can't come back because really I got a job I got to go to and I can't leave work and I don't have another $25. Can we do it all in one visit? And so it becomes really, really difficult to see the patient and make sure that you are providing adequate care for that patient and giving them everything that they need. So now I'm challenged with taking that type of patient and trying to teach the residents how to care for that same type of patient, but at a different location, in an academic location, and making or helping residents to navigate, well, what are social determinants of health? Because all they want to do at this point is learn about medicine, right? They don't care where the patients are coming from right now. And a lot of times they don't take those things into consideration. They're just ready to put into practice everything that they have learned. And so what I'm saying is that that's really challenging to help them understand, meet the patients where they are first, so that you can then apply all of that medical knowledge to give them the best care that you possibly can. And then we are now faced with the pandemic. And then we're faced with the killings of all of these people. And I'm talking about African American people specifically, because my residents see a large amount of them. And so you then have the challenge of walking into a patient's room and establishing trust now with a patient who can't trust you because they can't trust the system. We have a lot to do and a long way to go. But I think being here has really been very unique for me and very helpful. I think if we can get our residents to understand that the social determinants of health, where patients come from, how their upbringing is, what accesses to service they have, if we can get them to understand all of that, they will and can deliver the best care possible. I myself come from a background, my mother and dad weren't educated beyond high school. They both managed to graduate from high school. My dad was a farmer and a bus driver. So for me, we walked out the back door, got on his bus, he took us to school and he picked us up in the afternoon. And my mom was a cook, but the one thing that they learned to do was tell us that education was important. Daddy couldn't go to college because he had two little sisters who were still at home with his mom, and he lost his dad at 58 years old. So then you're talking about just that background with a lot of your patients. You know, in the African American community, a lot of times we put off our health because we're taking care of so many other things. Teaching residents that is so important. It's vitally important so that they understand that the people that they serve may not have access to all of the things that you had coming up, but you are here to help navigate that for them and to build that trust. I remember when we first had the first surge, and my mother had just had open heart surgery, and coming home to her and then to my husband and my two girls, what the heck was I going to do to prevent her from getting surge? I mean, from getting COVID. And then we had that big wave of positivity, even in our own clinic. So then you're having healthcare providers who are being affected. You've got to make sure that you're staying safe. Then you're going home to your family. I'm in a family now with my mom who has all of these medical problems. I could potentially expose her. What are we going to do? What are we going to teach? So I say all of that to say I take all of my life experiences from the community health center, from taking care of my own mother to taking care of the residents, and try to deliver the best care that I can for my patients, but also teach the best care that I can to my residents. That's kind of my background, and that's kind of my story, and that's what I do on a daily basis. I was just complaining to Dr. Anderson the other day. I said, I'm so tired. I'm tired. I can't keep up the pace with going to the community health center and then coming here and seeing patients and teaching residents. And then I realized I get another second win, and I go, okay, I'll be back out there Monday to see my patients at that community health center. So I love it. I love taking care of them. I love delivering care to them. And quite frankly, in Abbeville, they don't have a lot of resources. So they have come to depend on that community health center. We are able to provide them with not only medical services in the form of family medicine, internal medicine, pediatrics, but we also have mental health services there, we have dental services there, and we have pharmacy services there. So my patients can, all in the same clinic, get just about anything that they need without going outside of that clinic. And so for that reason, I can't give it up. And I think that that's a great source of information for me to bring back to my residents and teach them. So.
Thank you so much to all three of you for everything you said. It's really rich discussion. So I have a couple of questions, but I also want to open it up to our attendees. So if you're here as an attendee and you would like to ask a question, you can type it into the Q&A or into the chat, and we'll answer it. One question I was thinking of while you were speaking, Dr. Marshall, and I'm sure all of you, I know all of you could speak to this, is Dr. Anderson and I have had a lot of conversations, especially in our subcommittee, about, for the governor's COVID task force, health equity task force, is sort of the issue of having a pandemic with a virus that, when people get sick, seems to be clearly affecting the African-American community in Louisiana much more greatly in terms of sickness and death, and the issue of longstanding trust issues between the African-American community in Louisiana and probably across the South and across the country, and the field of medicine. And we know about implicit bias. We were talking about that a couple of days ago in the same symposium. And just one thing that Dr. Anderson has really raised my consciousness about is the issue of representation in medical school and amongst medical students. And I just want to know from your perspective what that's been like for you and how you think about that, or how you've witnessed that during this time, during COVID-19, when there's a socially problematic, politically problematic virus that's affecting people of color across our state. And there's a longstanding issues of access that you've all talked about, and issues of trust, and kind of how that dovetails with your experiences in academia and as teachers.
I can tell you, in medical school, I was so busy trying to just learn. I'm sure there were a lot of issues there, but you just kind of tend to push it to the back burner, and you continue to move. Moving back to the South by itself was like taking blinders off. I had never realized how, I don't even, it was just very different. And I had to acknowledge I grew up in that environment, and I didn't even know it until I left and I came back. And unfortunately, that's what's happening still in the South. So many people grow up here and they never leave. And so that cycle of thinking never changes. So you have to deal with that with patients. You have to deal with that with your residents. And it is a very difficult task to change someone's mind about something that is ingrained in them. For my patients, there are lots of them who will walk in the room and say they don't trust for XYZ. And so you have to tell them, then, I'm going to send you to someone that I have a relationship with, so you don't have to worry. But there's that constant massaging of that. And then from the resident's perspective, there are residents, and I literally had a resident who said to me, and I'm almost embarrassed to say it, I didn't realize there was any killings of African Americans going on in the nation. I totally missed that. And I thought, where have you been living? Why don't you know this? But I guess that concept was so foreign to him that he didn't realize it was happening. I couldn't explain that. But what it led me to believe is that, all of our backgrounds and our social upbringings are vastly different. And in order to meet that challenge, the residents that don't know that this exists, it's my responsibility to let them know. It's my responsibility to bring it to the forefront. We were in the process of creating a social inequities lecture series Dr. Anderson has helped me with that on several occasions. And we started with some forums, but now we want to expand that. We want to include those patients that Dr. Sells are seeing. You know, could we get a panel discussion on, you know, gender inequities? Can we get a panel discussion on other topics that are hot for people in medicine, where the majority of people don't even realize it's occurring? So I tell you, being in Lafayette, Louisiana has certainly revealed some things to me that otherwise I don't think I would have seen had I stayed in Michigan. I really don't.
And if I can just chat a little bit, and you know, of course, Dr. Sells and Dr. Marshall, of course, will talk on the clinical side, but I'm thinking about just kind of, you know, you talk about like, how does that translate, or what does that look like, you know, in healthcare? And I look at it from just kind of an administrative, you know, person who works with a lot of policy design and you know, process kind of review and things like that. And so I'm just going to say this because I'm never one to hold my tongue. But if we think about disparity, and we think about COVID, and we think about what COVID kind of brought to light, it's not a secret. I mean, this is not something novel. This is not, and Nick and Marilyn, y'all can come off mute and interrupt me at any time. Like, please don't think that, you know, by all means, because it's really hard not hearing comments. So if you want to like stroke the ego and just like, yeah, Chris, that's right, that'd be great. But, you know, there has been racism, structural inequity, disparity, which just means difference. And think of it, there's disparity in income, there's disparity in neighborhoods, there's disparity in, you know, in every structural design you can think of, there's disparity. So when we talk about what COVID has done, or what does that look like to you as a physician, or as a patient, or as, you know, someone in administration and medical education, like, to me, it just looks the same. Like, now just people are talking about it because it's like the hot topic, which drives me nuts, because I'm thinking, where was everybody over the last, you know, 60, 80, 100 years, when we've been sitting here screaming this from, you know, our little rooftops in our little red line districts, because that was what was created for. Like, but I can hear my husband telling me like, okay, settle down, calm down. But I also understand that it takes time. And there is time that everyone comes to the place where they are to arrive at that moment. So when Dr. Marshall talks about somebody who didn't know that, you know, African Americans were getting killed by the police, you know, when she told me that, I just was like, oh my God, like, what are we doing? And then I said, you know what? We're not doing enough. We're not doing enough. You know, and it is, and it's not a point of where we're going to force or make someone like, we're gonna drive this home, we're gonna drive. No, it's through our finesse, it's through our poise, our class, you know, it's through that elegant way in which a Dr. Sells or Dr. Marshall can say, you know, I think this is a great opportunity for us to just sit and just have a real big learning moment. Or, you know, maybe we should have a panel discussion about such and such. And you start to develop kind of that awareness and that knowledge and that, you know, adult education style through those methods. And, you know, and I think that's one of the things that I appreciate working with, you know, folks like Dr. Sells and Dr. Marshall, that allow individuals, and have created such a space for our learners or our patients or our staff to ask those questions that sometimes I'm just like, oh Jesus, like, what, where am I? You know, I'm in the ankle of the boot, which is enough right there, but that's where I am. but how can we transform or further educate or further expose people to, you know, what's going on, or try and think through the needs of our people at this time? What does that look like? And, you know, and it's a beautiful thing when we come together and figure out how to create an environment of education, of learning, of conversation and dialogue that that gives people, just for a moment, even if it's just an hour lecture, an hour noon conference, or an hour, you know, workshop, of just listening to listening to someone else's point of view, listening to someone else's experience. To me, that is kind of what this time has brought, because nothing has, you know, I think nothing has really changed that much, other than the fact that people are now just like, oh, wait a minute, I've got to think about what I'm saying. I've got to think, you know, which is great. Reflection is always great. But, you know, but I think it has given us a time and an opportunity to really have some conversations that we weren't having before, because we just didn't have the space. So
I have so we have three really good questions. I'm going to start with one of my students' questions, Brylan, one of my Dillard University biology seniors who's in the audience here. And he says, firstly, thanks so much for what you all are doing for the communities and people you serve. My question is for Dr. Nick Sells, and he says, what steps do you think will eliminate the myth that HIV positive people are contagious? Because as a biology student, I try to inform people about the virus, and it's like they still don't understand.
So great question. I think discussion. I think that's really the only thing. So we talk about U equals U all the time. Undetectable is untransmittable. But I think you're talking about just plain, we can hold hands, we can be in the room, we can drink after each other, just plain normal human contact. When I talk about U equals U and undetectable is untransmittable, I'm talking about more than just plain normal day-to-day contact. I'm talking about sexual transmissibility or further. You know, I tell my learners, so I have medical students, PA students, NP students, residents, whoever I work with. You know, I pose the question, which is if you had to choose between, say, diabetes or HIV disease in 2020, which would you choose to have and why? And all of them kind of fumble around and they think, well, what does Dr. Sells want me to choose? And then they're like, well, what if I choose the wrong one? And oh, yeah, you know. And so then after they get over their ego for a minute, about 2/3 of them, they're like, diabetes for sure. And then I say, well, which do you think I would choose? And they're like, diabetes for sure. And I say, no, 100% I'm going to choose HIV. And why am I going to choose HIV? And then they're going to be like, and so then I tell them the truth or the answer. And the answer is, I'm going to choose HIV because in 2020, just like in 2010 and in 2002, you know, HIV disease in the modern era is a chronic, controllable medical condition. It's incredibly complex and incredibly fascinating as a physician and a scientist and a researcher, but it's incredibly complex and incredibly exciting to care for a complex medical disease. That being said, if you take your medicines every day, there's literally zero excitability about it, like literally zero. It's well controlled, and I tell my patients, you're going to die of old age, just like me. It'll have nothing to do with your HIV disease. Whereas diabetes, when I think about the sort of ramifications of diabetes, even in well-controlled disease, we can talk about small nerve fiber neuropathies, and we can talk about renal ramifications or kidney ramifications, and we can talk about ophthalmologic ramifications, even in well-controlled disease. And I don't think people understand There was a study that was done several years ago that compared lifelong cost of disease burden between people who were HIV positive versus those who had diabetes. And it's shocking that people still think that HIV is so costly to society and so costly to the government. I hear that a lot from, well, I should be careful what I say. I don't want to say anything crazy. I told Dr. Anderson, just don't let me say anything crazy about my political views or anything. So, but sometimes people say, well, the government has to pay all this money for the HIV patients. Well, but the truth is that whomever pays way more for lifelong diabetes care than they pay for HIV care. It's about like way less than a fourth the cost lifelong to care for someone with HIV disease. The only thing in 2020 that I cannot fix about HIV disease or I cannot make better with my medicine is the stigma that's associated with HIV disease. And that's the unfortunate part. And the only thing that makes that go away is to have healthy, intelligent, that's the key, intelligent discussion about HIV disease. You can email me. I'm happy to help stimulate intelligent discussion.
Thank you so much for that answer. Thanks for the question, Brylan. So Zelma Lewis in the audience says, hello, I'm a fairly recently retired geriatric nurse practitioner who worked also in an FQHC with older adults in California. Since there's a shortage of doctors nationwide, what are you all doing to educate and support? And you just mentioned this actually, Dr. Sells. What are you doing nationwide? What are you all doing to educate and support nurse practitioners and PAs? And thank you for this very personal and passionate webinar. So you did just mention PAs and NPs, but if you have anything else to say.
I don't have anything else to say except you'd be happy to know that we have multiple NPs and PAs right there in the FQHCs where we are. And so I actually have a couple of them right now who I am the physician who kind of follows up with them on their work. So that's continuous.
Great. Thank you.
I'm their collaborating physician.
Thank you. And Dr. Stephen Farrow, who's I think been with us almost every night this week, so thank you, who's a physician, says, some suggest that COVID rates among the impoverished will be lower because of broader exposure to infectious disease in general. This despite that frontline minority clinicians and first responders have been disproportionately highly affected. How do you expect COVID to affect the impoverished, even with the discovery of vaccine over the next 2 years? And he says, and go blue.
Is this for me?
It's, I think, anyone who wants to respond.
So I think we've learned, I mean, even as recently published as last week, we're seeing that when we talk about impoverished persons, those impoverished persons can be in rural areas. There was a beautiful study that was published last week or the week before last that looked at rural healthcare outcomes in small rural hubs of less than 1,000 people, and their outcomes secondary to COVID-19 compared to those people who were from larger places, so to speak. And we saw that their outcomes were poorer, and their access to testing was poorer, et cetera. So from that perspective, I do think that overall, I think that the effect of the impoverished community is going to be relatively larger in terms of the gravity is going to be greater. I think there are lots of things that affect when we look at COVID-19. I don't even know if people quite understand. So there are so many things that are involved, right? When we talk about access to testing, when we talk about rapidity of testing, it needs to be, when we talk about testing, sure, you can go get a test at Walgreens, right? But if you don't get the test result back and it's an accurate, with high sensitivity and specificity result that you can trust and believe, then there's zero help, right? And then you can go like random places and get an antibody test, but none of us know what to do with an antibody test result. I don't know how to counsel you or tell you what that means. Like none of us know how long the antibody provides protective result, I don't know how much of that antibody is neutralizing antibodies. So I don't know how much of that is really protective at all. There's so much misinformation that it's almost hurtful. And so when I think about all the things that surround COVID-19, the impact is huge. The thing that I think matters to me the most is the ability to educate and disseminate information in a meaningful way that impacts people in such a way that there are people who don't have an option to socially distance in an appropriate way. And what are we doing for those people? And there are local governments that are doing that really well in some places. And then when we talk about homeless shelters and when we talk about some of our open drug use communities in the Pacific Northwest, they're doing some really brilliant things to provide safe alternatives for people to be able to have a socially distanced and safe environment with which they can still live in a COVID-free environment or a COVID positive environment, safely distanced away from other people, etc. So I do think that there are places that are doing that the impoverished are thriving a little better than other places. But I do think there's going to be a much more sort of profound impact on the impoverished than there is on, I mean, it's sort of the definition of disparity.
Can I say something about that too, Dr. Sells? I just had a question like this last night. I was on another seminar, and one of the questions was how do you tell if you were COVID positive? What do you tell people to do in their households? And even me thinking, well, you just isolate yourself and you go in a separate room and you have them bring you food, blah, blah, blah. You can stay there for 14 days. And they said, well, what if there's only 2 bedrooms and there are 3 people who sleep in each room? I mean, and that's a prime example of an impoverished area. I was telling Dr. Anderson and Dr. Sells yesterday, my husband is from a small town in Northeast Louisiana called Epps, Louisiana. It's in West Carroll Parish. And just in that parish itself, Epps probably has 600 people, okay? If it has that many. But we had a whole family affected by COVID-19 from going to a church service. They all lived together. So you had the father, the sister, the brother, the little niece who's 21 years old, 2 aunts who are in their 70s, all got COVID. One aunt died, one survived. Dad's debilitated, now in a nursing home. The brother, who's in his early 40s, survived after being on a ventilator. The sister, early 40s, died. 21-year-old, still in the hospital because they couldn't go anywhere else. Where were they going to socially isolate? And so you have to think about all of those things. What do you do with people who live, multiple people in a home that's not designed for that many people? I don't have an answer. Do you, Dr. Sells?
I wish.
Yeah, and it goes back again to, I think, the conversations that I think we have been having over, I mean, we've been working in the same public system forever. And these are issues that now we haven't had a pandemic, of course, but we still have issues with housing, about our homeless population. How do you discharge a homeless population, a homeless person with, a script and make sure that he's compliant with taking his medicine? Like, I mean,
listen, there is hope, because what I can tell you is that my patient population, if you come see me today and you're HIV positive today and you don't have anywhere to live and you don't have any food to eat and you don't have a car to get you to your doctor's appointment and you don't have any money to buy your medicine, you're going to leave your appointment today and you're going to have all of those things by the time you leave.
Yep. Absolutely.
We're doing that well with HIV. We're doing that well with some things. And so there is hope that it can be done well. But what's different is that nobody is standing up and protesting, and nobody is standing up and getting political dollars, and nobody is standing up and saying, somebody needs to do this. 33 million people have died since 1981 when HIV became a pandemic. That many people have not died when COVID happened, since COVID happened. But we don't want it to get there. But what I'm saying is, when we look at history and when we look, when we think about HIV disease, there is proof that we can use our government to make good sense of healthcare for people with no insurance, people with doesn't matter. We can give people what they need to be successful and keep them successful and partner in their healthcare. There's no reason we can't do that for everybody, for everything.
Right. Listen, there is a piece of this that, okay, here I'm going to get into my little rant, but when there are financial dollars, when there is a political stream of consciousness, when there is financial dedication of money and resources to advance an equitable framework, no matter what you're talking about, whether it's HIV, diabetes, obesity, when there is a conscious, deliberate framework that is put in place and the financial resources dedicated and the resources via personnel or what have you dedicated to that to provide equity, there is a way to strengthen the quality of healthcare. It doesn't matter. There's just, I mean, it's easy. I feel like it's something, okay, I'm going to tone myself down just a little bit, but I feel like we have these circular conversations about things to which, we know what needs to happen. But again, systems are constructed in such a way that the key stakeholders that own the power dictate where the resources go. And so when that happens, and there is a complete disregard for those that are providing the care, contributing to the care, or receiving the care or lack of care, it keeps the engine going that is structurally designed and determines the outcomes of the community. It's easy to think about, but it's just to have, you got to erase and move these people aside or get rid of them. And we do that through what? Through voting. We do that through putting people in places of power and position, whether it's local government, whether it's federal, national government. We've got to do something because people are dying and people are sick. When it's not COVID, we still have sick people. I mean, sick people. They are lined up in the hall. And COVID showed us that the fear that our Black and brown communities have or our disparate communities have was real. Because when the door kind of opened again a little bit, our line, and I would come home and I would just get so emotionally just exhausted because our line from the ED, when we have the overflow of how many people would just go into the ED, was all like a third of the way down the hall, which in my mind was just like, these people have been sick for a long time. They have been in their homes, scared to death, and are now just either in late stage or or just need help. They're sick. And what are we doing? What are we doing about it? Sorry.
So we have another question that I feel like you've addressed in many different ways, but just in case you have anything more to say, another one of my students, Prayani or Singleton, another biology major here at Dillard, says, good evening to you all. I would like to know, what are the key initiatives do you all take to address disparities? And I think you've spoken about this in a lot of different ways, but I guess I'm wondering if you have any other things to say about that.
Dr. Anderson?
No, I feel like I talk too much.
Okay. Well, I guess I would say what I've heard from you all is frustration about how late in the game everybody seems to be waking up to this because of COVID. Many ways that you personally address this in your own teaching, in your own approach to teaching, in your own work, in your approach to clinical practice, the ways that Dr. Anderson approaches this in the work she does. And I think, Kristie, you've, spoken really passionately about just the systemic changes that really need to be made. So I guess I would sum it up
Yeah,
that way.
and I think each in our own areas of specialty. I'm kind of policy behind the scene, kind of, social advocate. Nick deals with his populations, his clinical populations to which he addresses, disparity. But, Marilyn is with her, community FQHC also, within the residency. I mean, we all kind of have our unique kind of ways in which we address, educate, converse, teach, and we probably pop in and out of everybody else's, to figure out like, okay, what's needed at this time. So, yeah.
Great. I think that's pretty much it. There's one student who wants some information about a pathway to infectious disease and internist or family physician, but I think I might just get you in touch with either her or my class, either both of you or Dr. Sells, to answer that question. Because I think we have a lot of students who would like to know the answer to that question. So unless there's anything else that you'd like to say in closing, I just want to say thank you so much. This has been really wonderful, and it's been an amazing discussion, and we're grateful to you. So thank you. And I have many, many students in the audience that I think are really excited to have heard you. So,
Awesome.
so thank you very much for being here. I really, really
Thanks for
appreciate the
having
Thank you
time.
for the invite.
Yes,
Yeah, thank
thank
you very
y'all.
much.
Thanks so much.
Thank you.
Use your
Thanks for being
voices.
here. Yeah.